I go a little bit one step further where I don't just palpate and feel for where it's hurting, and then I just put a needle where it's hurting, because I think you're missing out on a lot of insight when you're not incorporating, really thorough diagnostics outside of, just pressing on an area and hurting. Although pressing on an area and making it hurt is really, really important in the grand scheme of things. It's easy to put needles in places once you know how to. The hard part over time is, where do I have to put the needle? In talking with other colleagues, in reading research, one of the things that I've come to realize is that the failure rate in my clinic, which I deem a failure in that somebody gets 0% improvement, where they come back to me 3 months later after PRP and they say, "Doc, I didn't get any better whatsoever." It's not like I got better for 4 weeks and then regressed. No, it's literally like I was sore for 3 days after the injection, and then I just went back to baseline and it never changed. That to me is a failure. That is on me. That is not, oh, I did prolotherapy and you needed PRP in order to heal. No, I think that's a cop-out. I think it is 100% on me as the diagnostician that I missed something somewhere. My diagnosis on what was causing pain or generating pain was off for whatever reason, and I have to go back to the drawing board and try to figure out why, so that I can do things differently. I also don't agree that you have to have multiple rounds of a treatment to see a response. If you put a needle in the right spot, whether it's dextrose, whether it's PRP, if it's in the right spot, you will see a response. It may only be 10%, but 10% is still a response. That's different than 0%. If somebody comes in and says, "Doc, I'm 0% better," I'm not going to say, "Okay, we just need to repeat this injection and sometimes it takes 2 or 3 for it to work." Unfortunately, that I think again is just and again, I don't think any of these cop-outs are intentional. I think there's some misguidedness across the profession in terms of why patients are not responding to these therapies. There are some patients who will not respond well because of metabolic disease, right? They got type 2 diabetes, they have connective tissue disorders, they have nutrient deficiencies, they've got chronic infections. All those things still factor in and are important in the patient's healing, but I don't think any of those are truly sufficient enough for a patient to have 0 response. And so that's what I'm always striving for here, is how can I make my 0% responders, my failures, less? And that always comes back to improving diagnostics.